Welcome to Cardiac Academy. In this video, we're going to continue our series on EKG interpretation. In the previous one, we talked about how to interpret EKGs in a systematic way following our very own mnemonic and how to calculate heart rate. So today, it's all about rhythm and arrhythmia. So without further delay, let's get into it. Okay, my friends, let's talk about rhythm. So when assessing rhythm, there are 5 main questions you want to answer yourself. The first question is, are there any P wave present? And that's important because the presence of P wave tells us that the depolarization is coming from the level of the atria. If there are no P wave, then they are coming either from the AV node or from the ventricles. Next, you want to assess whether there is a P wave for every QRS in a one-to-one fashion. And that's important because you want to make sure that the SA node is the one that is driving the depolarization. So if you start seeing P waves kind of marching on their own and QRS marching on their own, then that might suggest there's an AV block that needs to be assessed. Then you check to see whether the QRS is narrow or wide. A wide QRS could suggest that the depolarization is coming from the level of the ventricles, in which case you wouldn't see a P wave. After that, you check to see whether the rhythm is regular or irregular, and you do that by looking at the distance between R wave and R wave, and you want to make sure it's the same distance in each depolarization. And finally, you look at the PR interval to make sure it's not prolonged, because a prolonged PR interval could suggest there's a first degree AV block. So let's go through that. So first we said we're gonna look for the presence of P waves. So let's look at the rhythm strip, and yes, we see there are P waves for each depolarization. So that means that the SA node is driving the depolarization, or at least is coming from the atria. Next, we check to see if there is a QRS and a P wave in a one-to-one fashion. So we look, there are P waves, and after each P wave, there's actually a QRS following. So yes, there are P waves and QRS in a one-to-one fashion. After that, we look to see whether the QRS is narrow or wide. And earlier, we said that each small box represents 0.04 seconds. So let's write that. So one small box equals 0.04 seconds. And we also said that a normal QRS shouldn't measure more than 0.12 seconds. So normal QRS equals less than or equal or less than 0.12 seconds. So that means that a normal QRS shouldn't measure more than 3 small boxes. So equals 3 small boxes. So let's check that. So we look at this QRS and we see that there is 1 and 2 small boxes. So that would equal 0.08 seconds. So that's a normal QRS. After that, we check to see whether the rhythm is regular or irregular. And we do that by looking at the distance between R wave and R wave, and we want to make sure it's the same distance. So let's check. And we see that, yes, the distance is the same. So the rhythm is regular. Very good. And finally, we look to see whether the PR interval is prolonged or not. And a normal PR interval should be equal or less than 200 milliseconds, or 0.2 seconds. So that means that it should be longer than 5 small boxes. So equals 5 small boxes. Let's see. So we look at this PR interval and we count 1, 2, 3, 4, 5. So that means that the PR interval is normal. So after going through these 5 questions, then we can conclude that this is a normal sinus rhythm. All right, very good. Let's shift into arrhythmias. So there are 5 basic types of arrhythmias. The first one we're going to be discussing are arrhythmias of sinus origin. And this type of arrhythmia uses the normal conduction pathway, and they can either be too fast, too slow, or irregular. Next, we have ectopic rhythms. And in ectopic rhythms, these depolarizations are originating from somewhere else from the SA node, or somewhere outside the SA node. Following that, we'll be talking about reentrant arrhythmias, and this type of arrhythmias using an electrical activity that is trapped within an electrical loop. Next, we have pre-excitation syndromes, and this type of syndromes uses an accessory conduction pathway, and the classic example is Wolff-Parkinson-White syndrome. So, Wolff-Parkinson-White syndrome. And finally, we're going to be talking about conduction delays. So the first one, sinus tachycardia versus sinus bradycardia. So either too fast, too slow. This type of arrhythmia is going to be regular. It has a regular rhythm. So you're going to be seeing equal distance between R wave to R wave. And if it is more than 100, it's sinus tachycardia, because it's originated at the sinus node. If it is less than 60, then that will be sinus bradycardia. Easy. Then we start going into our first irregular rhythm. And this first irregular rhythm is called sinus arrhythmia. And sinus arrhythmia is a normal phenomenon that just reflects our slowing of the heart rate with our breathing pattern. So if you see here, during inhalation, the heart rate becomes a little bit faster. We can check the heart rate. So 300, 150, around 100 beats per minute. And then during exhalation, it becomes a little bit slower. So 300, 150, 175. So here is 100 beats per minute, 75 beats per minute. And the reason this happens is because during inhalation, there is the decreased vagal tone. And this decreased vagal tone is going to cause our heart rate to go faster. And then during exhalation, this vagal tone comes back to normal and slows down our heart. So you're going to see it's slightly irregular, but one important thing to notice is that you're going to see P waves. And these P waves are going to share the same morphology, all right? So if you didn't see any P waves, then you could start suspecting a type of arrhythmia outside the SA node. And if you start seeing different shape of P waves, then it will be another type of arrhythmia, which we're going to be discussing later, which could be a one-drill atrial pacemaker, if it is a normal heart rate. If it was above 100, then that will be called a MAT, so multifocal atrial tachycardia. But don't worry about that. We're going to be discussing that later, okay? In this type of arrhythmia, it's going to be slightly irregular. There's going to be normal P waves, and they're going to have the same morphology. Very good. Then we have sinus arrest. And sinus arrest just means that there's a pause. The SA node stops firing. And if nothing else were to happen, then you will see a flat line and the patient would just die. Thankfully, in our hearts, we have different pacemakers and around different locations in the heart, and they all have their intrinsic heart rate. So when you see this sinus arrest, there's gonna be a new beat originating from somewhere else in the heart, and these are called escape beats. And these are kind of saving the day, because if there was no escape beats, then the patient heart rate will just stop beating, the heart will stop beating, and the patient will die. So these escape beats can originate either from the atria, at the AV node, or at the level of the ventricles. And we're going to be discussing those, okay? Finally, prolonged electrical inactivity is called asystole or asystole. All right, my friends, let's finish up strong by discussing the different non-sinus pacemakers. So as we were saying, in our heart, we have different cells with their own intrinsic pacemaking activity. Normally, the fastest one to depolarize is the SA node and is the one that drives the heart rate. So the SA node has an intrinsic heart rate of 60 to 100 beats per minute. However, if there's a sinus arrest, then the second fastest is going to spring into action. The second fastest are the atrial pacemakers, and the atrial pacemakers have an intrinsic heart rate of 60 to 75 beats per minute. So we're going to go into detail in the next video on how to tell them apart, but just to give you a quick glance, the easiest way to do that is by looking at the shape of the P wave. So after you see that sinus arrest, you're going to see that the heart rate is going to slow down, but the P wave, the morphology of the P wave is going to be slightly different because it's originating from a different part in the atria. Okay, very good. Next one is the AV node. The AV node has an intrinsic heart rate of 40 to 60 beats per minute. And the thing that's going to give away that we're seeing a junctional escape rhythm or escape beat is that you won't see any P waves. Why? Because this depolarization is originating at the level of the AV node. So if it is at the level of the AV node, not at the atria, you won't see any P waves. Next, we have the ventricular pacemakers, and these ones are the most bradycardic of all. And the heart rate is from 30 to 45 beats per minute. Now, these pacemakers, since they're originating at the level of the ventricle, first, you're not going to see a P wave. It's going to be extremely bradycardic, and the QRS complex is going to be very wide. Alright, my friends, that concludes our video. In the next video, we're going to go into much more detail on the difference between atrial escape beats, junctional escape beats, and ventricular escape beats. And we're also going to talk about the difference between an escape beat and an escape rhythm. We hope you like our video, and I'll see you on the next one.